If you want to let people in, Laura.
It should start flowing in now.
Beautiful. Welcome, if you are joining us, to the Meningitis and Sepsis in Children webinar being hosted today, Wednesday, 23rd of October, 2024. Please note this webinar is being recorded. And welcome. It is delightful to have you here tonight. I am so pleased to see such a healthy level of registrations for this webinar. I have done a little bit of research to see what resources I could gather for this topic and discovered that there aren't any resources on this topic. And so I am absolutely delighted to have Dr. Claire Wilkin with us tonight, who is experienced in this, to talk to us about assessment, diagnosis, and immediate treatment of children for meningitis and sepsis. So welcome. I am just going to wait maybe one more minute to allow people to come in. Thank you all that have joined for being so prompt. That is excellent. Can always count on can-do doctors and nurses and health professionals to get to something on time. Thank you. I'm going to just wait until 4 minutes past 6, and then I am going to get the show on the road. So if you've just joined, welcome to the Meningitis and Sepsis in Children Assessment, Diagnosis and Immediate Treatment webinar. Claire, can you see my screen of slides? Cool.
Yeah.
All righty. I'd like to just do an acknowledgement of country. Now, I'm going to apologise to you all. You may be coming from other states in Australia and other parts of Victoria, but for me, I'd like to acknowledge the Northwestern Melbourne Primary Health Network is working on the lands of the Wurundjeri Woiwurrung people, the Bunwurrung people and the Wathaurong people, and I'd like to pay my respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Now, a little bit of housekeeping. You will probably all know this, but we've got two ways for you to communicate questions to us tonight. We've got a chat box, and you're welcome to put questions in there, and we have a Q&A, and that stands for question and answer. I will be monitoring both of those, and Claire has a couple of sections in her presentation, which is a little bit of a pause, and we're going to go over the questions relevant to that section then, so that it's all still fresh in your mind what we've talked about, and Dr. Claire will then answer the questions then. So please feel free to put your questions in. I know that Dr. Claire absolutely loves questions, so don't hesitate, but we will just have a couple of pauses to answer those questions. Now, keep in mind that this session is being recorded, and that when you put a question in the Q&A, that is anonymous to protect your privacy. Please make sure you have joined this session using your actual name. You'd be surprised how many people join with the name My iPhone, and that's really difficult to make out a CPD award CPD hours for you. So if you could join with your actual human name, that would be brilliant. Now, I'm just going to point out a very interesting thing to you. Every webinar that we give, we do a brief reminder to everyone about health pathways. Now, as you will know, Health Pathways is a up-to-date, relevant database for primary care practitioners, in the community, so that in acknowledgement that you're not actually robots, you can't remember every single thing. And so this database is there to help you navigate referral pathways and diagnoses and assessments and other things like that. And it is written by other practitioners in the community. Now, in Victoria, we have about 5 of them, and you join the one that's specific to your region. Most states of Australia do have health pathways, except for Western Australia. So this is what a health pathways page looks like. This is one for paediatrics. Okay, that lady gives a very good explanation, but I'm going to summarise it just for the purposes of getting this done quite quickly. This is a landing page. You will be familiar with a search bar where you put what it is you're looking for in. Down the side are links, and in the middle is a bit more information. Now, if we go to the next slide, which is the pathways for meningitis and sepsis, when I had a look at this, this is prepared for me by the Health Pathways crew, I was somewhat dismayed to see that there is nothing specific to meningitis and sepsis. And I was about to sort of go back to them and say, listen, you guys, you need to amend this, when I thought, hang on, I'll have a look at Dr. Claire's presentation first just to see what sort of things she would be saying. And having a look at that presentation, I then understood that there does not seem to be clinical pathways, diagnostic criteria and aids, which is why it is so hard to diagnose sepsis. So they are very related links, but you won't find anything specific to meningitis or sepsis in health pathways. Now, just a quick note, you know that Health Pathways logins are changing. You're going to have individual logins from 30th of September, so last month. And to sign up, just Google Health Pathways for your state, except for Western Australia, or if you're in the east or northwest of Melbourne, that is your file path, or you can use the QR code. Now, Dr. Claire Wilkin is a paediatric emergency physician at the Royal Children's Hospital, and she specialises in pre-hospital and retrieval medicine. She also holds a master's degree in aeromedical retrieval. Additionally, Claire plays a vital role in the Medical Advisory Committee for Ambulance Victoria, contributing to guideline development and education. Her career has included working in Australia, the UK and Africa. Claire gave a riveting presentation earlier this year on respiratory illnesses in children that had many clinicians asking when she would present again, and I can absolutely attest to that. It was extraordinary. We had such good feedback. Claire is a very articulate speaker. Now, Claire has just come straight off shift, so please now welcome Dr. Claire Wilkin to present on meningitis and sepsis in children.
Thank you, Della. Now, did you want me to share the presentation from my screen? Is that easiest?
Yeah, and just click through and pause when you want to, and I'll look at the Q&A and chat box.
Okay, let's see what catastrophe we're going to get when we do this. There we go. All right. Welcome, everybody. I always find this a little bit tricky, mostly because I can't see you, but you can see me. So please do send through any comments, questions. I'm happy to stop and answer questions as we go through. As Della mentioned, there's a couple of areas within the presentation that do allow for us to stop and answer questions. But if there's anything that's really burning or that, you know, we really feel that we can't move on until I've answered, very happy to do so at any point. So essentially today I was asked to talk about sepsis primarily, and then some other bits and pieces that are also involved in that, which is around the confusion that is meningitis, encephalitis, and what constitutes sepsis versus those other things. So sepsis is our main focus, but we will talk about those other bits and pieces as well. So the main thing that we think about and the times that we start to consider thinking about sepsis is when we've got a child with a fever. So we've taken a temperature, we find it's over 38 degrees, and we've got a family or a parent who's very concerned about their child at that time and what they might do. So that's fine. Like many things, we've got lots of guidelines and evidence to help us here. And here's some of the many guidelines that exist in the world for the management of sepsis and fever. And I always have a thought process around guidelines, and that is if there's more than 2 columns or you end up with a flow chart that's got bits and pieces that go around in circles or off in 15 different directions, it's a little bit of a red flag for me that maybe we don't quite know all that we need to know about that particular condition and how best to manage it. And this is certainly one of those times, and you can see that from some of those guidelines sitting up there on that list. So despite all of those guidelines that we still have news headlines that look like this. Now, I guess without talking in too much detail about some very unfortunate things that have happened throughout the country, and it's certainly not just in Victoria, but elsewhere in the country, where we have had patients pass away, both pre-hospital, in the community and in hospital waiting rooms.
Excuse me, Claire,
Yeah.
I don't know that your slides moved on. Yeah, they're not progressing. We're still on sepsis first, then some other brain things.
Oh, okay. It's saying you are screen sharing. Let me see. I'll stop sharing and try and share again and see if that changes.
Yes, now it's on 2, but despite these, do you want to just flick it over to the previous one to make sure?
Okay.
Yep. Okay, good. We're cooking with gas now.
Okay.
Excellent. Thank you.
Very exciting. That was the fever thing. There we go. I've stolen all my own thunder here. I'm not doing very well. Okay, there we go. So there's the guidelines I was talking about. As you can see, lots of different directions that things can move in and sort of circular options for things. And some news headlines there. So unfortunately, the vast majority of patients that do pass away in these circumstances do so from one particular bacteria that we will talk about a bit later on, but they're all related to sepsis. So it's why it's that condition that we really need to think very carefully about. So when we're thinking about fever in children, the vast majority of children will have a non-sinister cause for their fever. And that's probably the most important thing to remember as we move through this presentation, which can get sort of fairly scary at times. But the most important thing to remember is most children don't have one of these problems. So the main things that we're thinking about when we see a child with fever is making sure that they don't have one of these problems. So meningococcal disease, which thankfully is something that is certainly decreased in our community now, but still exists on occasion. Invasive group A streptococcus, which we'll talk about in some detail, and this kind of overarching concept of sepsis and what that might mean. So this is sepsis. Sepsis is life-threatening organ dysfunction that's caused by an abnormal host response to the infection. We need rapid diagnosis, but we also need to be thoughtful about who we're diagnosing with sepsis, because overdiagnosis also has significant consequences. Most children with fever, as I said, with or without a focus, that's not critical, do not have sepsis. And I can't emphasize that more in this presentation. When we talk about sepsis, we also talk about this concept of septic shock, which is sepsis with evidence of cardiovascular organ dysfunction. Okay, in adults, we look primarily for hypotension, but that's a very late sign in children, so we need to look for other signs that would predate that hypotension. The treatment of sepsis is actually relatively straightforward, and we do have excellent guidelines for that. And that involves rapid vascular access, early initiation of antibiotics, and carefully titrated fluid resuscitation. And we've got really good guidelines for those things, which I'll pop up a little bit later on. But the most challenging thing for sepsis is around the diagnosis. Hold on, there we go. So what can we do for these kids? And the answer is that we can think very carefully about our high-risk groups for sepsis. So neonates. So little babies, particularly under 28 days and even extending up to under 2 months. Immunocompromised children, those receiving chemotherapy, those on high-dose steroids, or receiving immunosuppression for some other reason, or with underlying immune disorders that make them immunocompromised. So thinking about those children as a separate entity. Children with central venous access devices because of long-term treatment of a particular condition, largely in the oncology space, but there could be various other conditions such as metabolic conditions where those might be used, and our Aboriginal and Torres Strait Islander children. So we're actually going to take that cohort out of our conversation today because these children are high risk and they need specialised thought processes around assessing them for fever and other conditions that may expose them to sepsis. So how do you recognise sepsis? So here's a list of things that you can do to recognise sepsis. Okay, so we've got altered conscious state, unwell appearance. Now, I've put that in inverted commas because that's probably the biggest challenge that we have. What does an unwell child look like? Particularly in the emergency department, people don't bring their well children to the emergency department. So in theory, we could say every child that comes through the door on some level is unwell. But what does that actually look like? So these are the things that are listed as ways for us to recognise sepsis in our patients. But these are really quite tricky. And you've got a clinical features list at the bottom there that really probably lists many of the patients that you all would have seen in clinic at least once today. Fever, vomiting, diarrhea, myalgia, and things like that. They're all pretty generic, non-specific symptoms that in a child with a viral illness, we would see that every single day. So it's not, it's kind of difficult to work out how helpful this actually is. But what we're actually looking for is a sick child. So not a child that's a little bit unwell from a fever and vomiting, but a child who really meets that criteria of being a sick child. So our main issue with sepsis is that we've got more questions than answers. We do not have any useful sepsis screening tools in paediatrics. And even the definition around which observations and which particular abnormalities constitute sepsis in children is not agreed across the world. So they're probably our two biggest challenges, which is not to say that we can't diagnose or manage the condition, but there are challenges sitting in the background for us to do this. So if we're talking about that previously well cohort, so we're not talking about the children with long-term complex medical illnesses underlying their presentations. We're not talking about the neonates and the other complex children that I listed earlier. We're talking about the previously well child who's now presenting with a febrile illness. And how do we pick that child with sepsis out of that seemingly never-ending tidal wave of small children with viruses? So the things that we do know is that viremic children are very hard to differentiate from septic children. So we need to have, I guess, a thought process and a structure around how we're going to do that. Children have a very labile physiological response to fever, which is why just using our observations is not always helpful because it doesn't help us to differentiate those children. And the sepsis screening tools that we do have a very low positive predictive value in children. So we simply can't use the adult tools and then use them in children. But we do know that sepsis can be rapidly progressive and it does kill patients quickly. So what do clinicians do with the information that we have? The guidelines provide clinicians with long lists of signs of a sick child. And the tragedy is by the time those signs are elicited, the patient is often a long way down the sepsis spiral and can be quite difficult to retrieve. So if we look at these sick child lists, there's a couple of examples there. But if you read through some of those, they're sort of things that we don't really need a list for. Because if you were looking at a child who had many of these things, and these are things that are listed as the ways to recognise sepsis recognition. So that they're how we're going to recognise sepsis. And these things are not particularly helpful. So if you want to look at this list, I've sort of summarised it here, and there's several papers that list many of these things, often written by intensivists, as a way of identifying children needing intensive care assistance for their sepsis. So we've got need for ventilatory support. So you've got a patient who can't breathe, a patient with poor oxygenation, so they can't oxygenate their tissues, a patient with profound hypotension who can't maintain perfusion, a patient with a raised lactate or cardiac arrest or fixed dilated pupils. And that's not really very helpful because these are all markers of children who are already dying, and that's not the point at which when we want to pick up their sepsis. We want to have done it many, many hours before we reach this point. So we want to find the child before their peri-arrest. And that's where the challenge lies. So how do you look at, on the sea of winter fevers and sickness that are caused by flu, COVID, RSV, mycoplasma, adenovirus, and pick the one child who's sitting in this very busy waiting room who may have invasive group A strain? So if we look at this waiting room here, and this is a real waiting room during COVID in China, and the vast majority of the patients in this room almost certainly had COVID or some other viral illness. But finding which of the children in this waiting room is the one child that might have an invasive infection or strep, how do we find that child out of all these others? So we can go back and risk stratify our patients. And that's the same list that I had before. So those children are the ones that we need to pull out and really think about, why aren't we going to treat this child for sepsis? Is there anything in the information we have about this child that means we shouldn't treat them for sepsis? Because the vast majority of these kids actually do need early intervention for sepsis because of their underlying risk factors. So there's no guideline that helps us with the other children, the previously well children, the vast majority of children that we're going to meet every day. We can't predict the severity of their illness by the degree of their fever, how fast it happens, whether it responds to Panadol and Nurofen, whether or not they have febrile seizures, whether the parents are concerned, and most specifically, we can't use resolution of tachycardia after defervescence. So that used to be something that we used quite a lot. We'd give Panadol and Nurofen, and then if the fever went down and the tachycardia got better, we would assume that the patient didn't have sepsis, and that was kind of a differentiator. But we now have evidence to suggest that that's not particularly helpful. And so we come back to this statement that I said before, and that is that the appearance of the child is the most useful indicator. And that's what you'll see throughout so many of the guidelines. And that is, in fact, really all we're left with. There's some degree of comfort to say that the rates of things like meningococcal and pneumococcal disease are now profoundly low because of vaccination. So both of those conditions are now very rare. They're not impossible. They absolutely do still happen, and we need to keep them in our mind, but they are much, much rarer than they were certainly when I started practicing a while ago. So thinking about what I was saying about the antipyretics, this was the particular study that I was talking about, looking at, does giving antipyretics in the ED to improve the vital signs help us to rule out a serious bacterial infection? So what we're looking for is that needle in a haystack. So febrile children are the bread and butter of what we do in paediatric emergency. They're almost always tachycardic and tachypneic, but we still know that only about 10% of those will have a serious bacterial infection. Now, serious bacterial infections include things like urinary tract infections, pneumonia, and other sorts of infections like that. So not always something that would be classified as sepsis, but just a bacterial infection that requires antibiotic treatment. So we used to have this theory that if they were more tachycardic, tachypneic, any of those things, then they must be sicker. And so we have these Victor age charts that allow us to plot the patient's heart rate and respiratory rate to determine who's sick and who's not. And then we would give our antipyretics, we'd give our Panadol, give our Nurofen, and reassess. Now, we already know that Panadol and Nurofen don't make a lot of difference to your fever, but they do make you feel better. And that's the reason behind us using those in febrile children, rather than to try and change the height of the fever. But we did used to do this, and then, if the patient defervesced and their heart rate and respiratory rate improved, then we would be able to send them home, even without necessarily identifying a focus, because it's most likely that they have a viral illness. But this study kind of made us doubt that a little bit. It was a single centre data study that was done in a large London metropolitan teaching hospital. It was a prospective cohort study. They did have quite a few children, and did occur sort of pre-COVID, so prior to that big influx of a specific virus. They basically included all the children with fever and with greater or equal to one warning sign of a serious bacterial infection, which is basically tachypnea, tachycardia, etc. And the children that received an antipyretic. They defined their serious bacterial infections using cultures, using microscopy, virology, and imaging results, and the use of an expert panel where it wasn't clear. They excluded all of their most unwell children by excluding the immediate triage category and those with a complex medical history, and those that were discharged or had some other presenting issue. Essentially, looking through all those different, tachycardias and tachypneas, they tried to work out whether they were predictive of the child ultimately having a serious bacterial infection. So they found that persistent tachypnea after defervescence was a predictor of pneumonia. So it was good for ruling pneumonia in, if that was something that they found and were concerned about based on history. But persistent tachycardia did not independently predict the patient having a serious bacterial infection. So isolated tachycardia was not a useful predictor for whether they needed an admission or whether they actually needed significant interventions. So the conclusion from that was that the persistent tachycardia alone does not appear to be linked to a higher incidence of any underlying bacterial infection. And persistent tachypnea in an afebrile child was a useful predictor of pneumonia. So that was the one piece of information we got from this. So there was no real benefit in giving antipyretics and awaiting normalisation before discharge in febrile children with tachycardia, and no other abnormal finding because it wasn't a helpful differentiator. So equally, assuming wellness in a child if the heart rate and the respiratory rate resolve with effervescence is also not justified. Because the problem was they had a child that died of sepsis several hours after discharge where they had recorded normal vital signs. And remember, there was 1,455 children in this study. So one child still died of sepsis despite going through that process, and the ultimate answer being that they had normal vital signs at the point of discharge. So that's not reassuring to us either. And that's pretty much what happened after we sort of read this study and went through it all and went, oh, so this process that we've been using really for quite a long time to help us differentiate the patients that are and are not unwell wasn't actually particularly useful. So there's another study which was done peri-COVID, looking at febrile children in the emergency department and whether there were predictors of poor outcome that we could look at going back as a retrospective cohort study. And the idea was to determine the frequency of poor outcomes in undifferentiated children presenting to the ED with fever and to try and work out who would be most at risk. So they included all the children with fever and they didn't exclude any cohorts. They used data essentially from electronic medical records to try and work out both the things that happened to the child and what the outcomes were. Poor outcomes were defined as development of new organ dysfunction, plus or minus the need for organ support. And the need for organ support therapy was things like inotropes, mechanical ventilation, renal replacement therapy, or ECLS. They had a look at various different predictive variables, including things like heart rate, respiratory rate, blood pressure, and Glasgow coma scores. They assessed blood tests where they were done in certain patients, looking at lactate, creatinine, white cell count, platelets, and INRs. They also tried to use several clinical scores that are used in adults to try and determine whether they were helpful in predicting who went on to need organ support. So they had a cohort of 6,217 children, most of whom were actually in that younger age group. The vast majority were discharged home, and of that group, only 0.5% were admitted to the paediatric intensive care unit. Only 0.4% developed new organ dysfunction, and 0.2% required organ support therapy, which is reassuring in that it reinforces to us that the vast majority of children presenting to the emergency department with fever don't actually require significant intervention from a PICU perspective. But the important thing was that all the predictive variables were poor predictors for the development of new organ dysfunction. So we actually don't have these really solid predictors that allow us to identify which children are more likely to need support or to have sepsis in the first place. So as I said, the most important thing is that poor outcomes in undifferentiated febrile children are rare, and most patients can simply be discharged without any additional interventions. Only very few percent, 0.5%, required the close observation in PICU, and even fewer than that required support for organ dysfunction. But the rarity of the outcome reinforces that the use of the existing predictive variables isn't actually helpful. And that's because sepsis is a rare diagnosis in children. So there were a few hidden pearls in here, and that is to know that the high heart rate and high respiratory rate were actually not particularly helpful. They didn't predict having an increased risk of sepsis or requirement for organ support. The lactate in the patients that they measured a lactate, which may well have created a bias just straight off the bat of the patients that got a lactate taken, so they had a blood test, may well have been at increased risk of having organ dysfunction in the first place, which is why the test was done. They did have a slightly increased risk of new organ dysfunction and requirement for support, and the higher the lactate was that was recorded, the higher that risk. There was also some evidence that a high INR or a high creatinine may also have increased the risk. But of course, this was likely only done in the patients who clinically appeared to be more unwell and therefore were more at risk at baseline. The clinical scores that I mentioned were definitively unhelpful, so they did not help us to differentiate who had sepsis and who did not. So where does that leave us? Kind of in the same place we started. We're still looking really for the needle in the haystack. But the thing that we're specifically hunting now, and the thing that causes, I guess, the most worry and concern is this particular beast. And it doesn't actually look like that, but that was just kind of a cool beast that I found while wandering through the internet. So we're looking for invasive group A strep, otherwise known as IGAS. And IGAS is defined by the isolation of the group A strep bacteria from a normally sterile site. And mostly we see that as bacteremia or septicemia. We see it in streptococcal toxic shock, which is a variation of that sepsis. We see it in necrotizing fasciitis. We see it in severe pneumonia and empyema, in retropharyngeal abscesses, osteomyelitis, or septic arthritis. So all of those things, clearly serious bacterial infections, and they are the things that define invasive group A strep. These other conditions, cellulitis, scarlet fever, and pharyngitis, are not considered to be invasive disease. And this is really important. This is the same bacteria that causes different diseases. So one thing does not lead to the other. So having group A strep pharyngitis does not lead you to have group A strep sepsis, and the same with cellulitis and scarlet fever. So it's really important to remember this is the same bacteria causing completely different diseases. So what do we do then about sore throats? So positive throat swab reflects asymptomatic carriage in up to 20% of the population, and it's literally irrelevant. There is no evidence that treating sore throat with antibiotics decreases the risk of invasive group A strep, except in certain high-risk patient groups. And that includes our Aboriginal and Torres Strait Islander children, patients with significant immunocompromise. And as I said, we're taking those patients out of our conversation today because they often require antibiotics because we have a lower threshold to treat them because their risk is higher at baseline. So the vast majority of patients presenting with invasive group A strep have never had a history of group A strep pharyngitis or anything resembling it. So patients who have a sore throat, we should just continue to treat them as they have a sore throat, which is just the vast majority of viral. And in fact, there's very little evidence that treating invasive group A strep specific pharyngitis with antibiotics makes any difference to the risk of invasive group A strep and doesn't decrease your illness by more than a couple of hours. So it's probably not worth fighting the children to take antibiotics for strep throat. They'd be much better off taking the analgesia for strep throat and being able to drink and avoiding hospital admissions because of low oral intake. So how do we pick sepsis? So unfortunately, there is no list other than that terrible sick child list that we saw before. And once we reach the point of using the sick child list, our mortality is already climbing, and it's the highest of any childhood infection in the developed world. So what that tells us is we need to think about our febrile children. We need to look carefully for a source and remember that teething does not cause fever, despite all the old wives' tales that exist in the world. We need to keep our eyes on them and observe them. And sometimes that's already happened at home by the time we see the child, and we can hear the family telling us about what happens when they give Panadol, what happens when the child's had something to eat. Do they feel that the child's getting worse over time, or are things kind of going up and down, or are they overall improving? And they've actually, by the time they've come in to see you, actually they're already on the improve, and that makes it less likely. And doing those kind of serial observations to get a sense of what's happening over time. So this is a picture of my son. He is one of those special children who is significantly immunosuppressed, and therefore he's at higher risk. Now, in this photo, he actually has sepsis, which was not evident at the time I took the photo, even though it kind of looks like it might have been. And so we have this sort of list of symptoms that we think about that are more likely we're going to think of sepsis. So if you look at this picture of my son, he doesn't look great. He looks pretty terrible. He's flushed. He's very flat. He's lethargic. He's not difficult to wake, but he just takes quite a bit of effort when we're trying to get to him there. So we look at these things. We look at persistent tachycardia. Even though we know that that's not on its own a sign of sepsis, it's still something that we put into our mixing pot when we're thinking about patients with sepsis. Patients who are flat and very lethargic, thigh pain, and we'll talk about that one in a minute. Patients who are refusing to stand or walk, anyone with grunting respirations, headaches in preschoolers are things that we want to think carefully about. And widespread erythematous hot-looking rashes. So not we're not looking for the petechial rash as our definitive sign of sepsis. We're looking more for this sort of hot-looking rash. Decreased perfusion is really critical, so measuring that central capillary refill time in every single febrile child that we see, because if we've already got those obvious changes to perfusion, that's when we need to start thinking very carefully. And patients who are just unwell looking, I don't think anyone's going to look at this picture of my son and say, oh yeah, he looks great, looks really well. He's pretty clearly unwell at this point. Remember that hypotension is a late sign, and that really by the time these children are unwell, we should be able to take our blood pressure. Hypotension is a late sign, but if you're chasing the child around the room to measure the blood pressure, that's probably less of a risk. So having said that we don't have a list of things that we specifically can correlate with sepsis, we did a bit of a straw poll, I guess, asking 19 PEM physicians, which of the following symptoms make you suspicious that a patient might have invasive group A strep? And you can see how that differentiated along the lines. And there is lots of different things that different people are concerned about. But I think the two that stand out for me are still the tachycardia, even though, you know, we have this evidence that says the isolated high heart rate is not enough for us to predict sepsis. I think it might be if we're combining it with other things. And probably the other two that stand out are drowsiness, which certainly people were quite adamant was one that they really picked up on. But you'll see the other one that's really flashed up there is the leg pain. And particularly thigh pain is one of the ones that we commonly see children complain of, who we subsequently do find have invasive group A strep down the track. So leg pain is probably one of those things that we really do think very carefully about it if we've got a child complaining of that. Not so much the calf pain that you see with things like flu and COVID, but definitely that sort of thigh aching kind of pain is something that we would certainly be very thoughtful about. So here's some things that are not usually associated with sepsis: well child, normal observations, isolated neck pain, a single febrile convulsion doesn't make you any more likely to have sepsis. The speed with which your fever appears is not associated with sepsis. Runny nose and cough, running around the waiting room, and what the height of your fever is, there's no correlation with that being sepsis as well. So there's lots of things that I guess float around in the community as being concerning components of fever, but none of these things are specifically associated with sepsis. So there is no good predictor for paediatric sepsis, and recognition is hard. And I don't think anyone would be doing us a service to suggest otherwise. Viremic children will often meet those classic SIRS criteria that we use to identify very unwell adults. Observation is really critical, and I can't emphasize enough to make sure that we're treating those high-risk children. Those children are less safe on an observational pathway, and we need to be carefully thinking about how we manage them and having a much lower threshold for treatment of bacterial infections. So then people often say, but doesn't sepsis come with a rash, specifically this rash? So this is a sort of non-blanching petechial type rash. And previously the answer was always right. If you've seen petechiae all over your patient, you've got to run and get yourself some Kefixetol and quickly give that to the patient because they've got sepsis, and you know that's how we solve that problem. But petechiae are not the be-all and end-all in diagnosing sepsis. And in fact, the vast majority of patients that I see with sepsis don't have petechiae at all. The most common cause actually of petechiae is local compression. So certainly coughing and vomiting will give you raised intrathoracic pressure, and therefore you get lots of petechiae kind of above that nipple line, neck, face, all around that area. And that is no indicator of anything except that episodic raised intrathoracic pressure when they have been coughing or vomiting. It's certainly not indicative of sepsis, and it doesn't need investigation. The other time we see significant petechiae is in what we call Bjorn legs, which is this kind of baby carrier that you can see here in the picture, where the babies are literally hung by their groin. And what that does is cause local compression over the inguinal vessels. And that results in onset of petechiae in the next sort of few hours after that, often starting in the feet and progressing up the legs. Again, these children are very clinically well. There's no fever. There's no other signs of sepsis, and they'll have that clear history of being in one of these dangly baby carriers. The same things can happen with tight clothing on ankles and wrists. Baby socks are not designed to stay on babies' ankles, and so parents often get the ones with the really tight ankle elastic in the hope that they leave their socks on. and that can often result in significant enough compression to develop petechiae over the feet. So if you have a patient with petechiae and the child is otherwise clinically completely well, they are safe to observe. So if the child isn't unwell, you can simply mark the petechiae using a pen and observe them for a period of time. If there's no progression of the petechiae, it's very unlikely that they have a sinister cause. Again, we have to be more alert in those at-risk groups. Obviously, if there's significant progression of the petechiae or the patient is significantly unwell or concerned, then you should refer them for bloods. And we look mostly for doing an FBE and a blood culture, and then giving a third-generation cephalosporin if we're in doubt about it. This is not something that's isolated to meningococcal disease, which I think is what many people associate it with. It's present in almost all of the significant sources of sepsis. You can certainly develop a petechial rash, but many of the enteroviruses also cause a petechial rash. So it's not a good differentiator for sepsis versus anything else, but something to keep in mind. All right. Della, if anybody's got any burning questions now, I'm happy to do them before we start talking about one of these other cheeky bacteria.
Before we start talking about raspberries.
Indeed, those two.
Okay, yes, we've got some questions here. Firstly, what is the current vaccination coverage for vaccine-preventable community-acquired causes of meningitis and sepsis?
So at the moment, there's a fairly strong uptake. So the meningococcal vaccine is certainly part of the national schedule for immunisation. And most children now sort of under the age of 5 have, assuming they're fully vaccinated, have received a full course of both ACWY and evolving into that MenB category as well. So the amount of meningococcemia that we see is very, very low. There are still some cases that sit outside of the vaccine typable strains. So it's not impossible that we see it, but certainly it's very, very suppressed in the community and much less common that we see it. The same for Haemophilus and for strep pneumo as well, very suppressed in the community because of the vaccination. So there's not a lot out there, but it's still possible, like many of our vaccine preventable diseases, we're not covering every single available type of the bacteria that exists. So we still certainly do see them, but very strong coverage across the community now.
Great. Okay. Claire, can you please explain the high INR link?
High INR happens mostly in the patients who do have sepsis or significant organ dysfunction, and it's a sign of sort of looking at that DIC or that diffuse intravascular coagulation which comes along with sepsis. So it's sort of one of those markers really of significant end organ dysfunction where the patient's actually got really an autoimmune coagulopathy occurring as a result of the sepsis. So looking again at that abnormal host response to the bacteria that they have there. So that's really where the INR comes in. An INR in a well patient, it won't be reflective. So hence why I'm saying while those things are good predictors of not good predictors, but they are predictors of sepsis, that's probably a patient in which we already have realised that they have sepsis. And I suspect the INR would have been a very late indicator of the patient's unwellness, if that makes sense.
This next question is really interesting. I don't know whether you will be able to answer it.
I'm happy to try.
Yeah, give it a bash. Do we consider kids identifying as Maori as high risk?
Ooh, a good question. I don't know. I'd have to have a look specifically. Certainly, we have a significant number of Pacific Islander children that we see in the emergency department here. They've not specifically been identified as higher risk as compared to the Aboriginal Torres Strait Islander population, where there seem to be specific risk factors, particularly around Group A strep. And I don't know that we've necessarily understood all the reasons for that, whether it's sort of genetically based or there's some other component that comes into that. I'm not aware of that being identified necessarily in our Maori or other Pacific Islander groups. But it's certainly something that I imagine the local knowledge, particularly in New Zealand and in those areas, may well be different to that. But we don't at this point have different, pathways for those groups.
Yeah. Okay, then thank you. Okay, that is all the questions. No, hang on, sorry, one more. What do GPs look for in primary care situations as the blood test, etc., are not readily available? And this is something I was going to ask you myself. When would they direct them to an ED?
Yeah. And so I think this is always going to be a challenge. The vast majority of these patients, I guess you're going to see them in primary care relatively early in their illness. So it's really going to be obviously taking a really detailed history about how long the fever has been there. You know, there's basically no child who's had a fever for 12 hours that needs to go to an emergency department. We're going to have no additional information than what you already have. It's really looking at that history. Is the patient getting worse? Are things deteriorating? Are you starting to see any of those signs of end organ dysfunction or, you know, other needs for the emergency department? They're not drinking, they're dehydrated, etc. Those components. Do you have an obvious cause for the fever in front of you? Has the patient got, you know, lots of cough and snot? Do they have obvious gastro? Is there anything else that, you know, you can assign that fever to? And none of these systems are perfect. There is no perfect way for any of us to identify the patients with sepsis, but it's really about taking that history and examination and trying to identify the patients that we feel are more unwell than we expected for what we've heard their problem is. And they're the patients that probably require a longer period of observation. And that may well happen in a hospital waiting room, where obviously we have the capacity to have that longer period of observation before we discharge the patients home. But really, it's about how things evolve from the point of view of fever. There is no list of things that you can do as a checklist to say, oh, the patient doesn't have these things, therefore they don't have sepsis, or the patient does have these things and therefore they do have sepsis. That simply isn't available. So it has to come down to, you know, using your clinical judgment and to taking a thorough history and a thorough examination to see if you can identify any of these components that would place the patient at higher risk of sepsis, or any early signs of the end organ dysfunction that you might otherwise be looking for. Does that kind of make it? Is very tricky. There is no list, and I think that's the bit that does make it difficult. There is no way to be 100% sure all the time, and I think the thing that we do that I would always encourage GPs to do as well is to provide that really clear list of red flags. If you feel your child is getting worse, then you need to go to the emergency department. If they're developing severe leg pain, if they're becoming very drowsy and you're having difficulty waking them up, if they're not drinking, give that really clear list of red flags that would identify deterioration to families and, you know, give them that information and empower them to seek that assistance again if they feel things are not, you know, not getting better and in fact their child is deteriorating, because that's really the time where it becomes easier to identify the sepsis and where we need to see them in the emergency department. So I think it's really about providing those red flags and safety netting the patients as well.
If a clinician decides to advise the parents to take the child to ED, do you have a mechanism by which they can give you some of the history that they've already gathered, or do you guys need to take the history yourselves from scratch?
Oh, very happy to have, you know, provision of a letter, and obviously it's going to be emergency department dependent, so I can tell you what we do here, but it's different in different locations. Certainly providing a letter that the patient can bring with them is probably a fairly safe way of making sure it gets here. You know, obviously we don't have capacity to receive things by email. We're not permitted to do that under the Department of Health regulations. So we can receive things by fax because it is in fact 1985. And, you know, so it's not reliable how to do that. So I will say, you know, by all means, give the information that you've gathered to the patient or the parents to bring to us. And most of the time we will be in receipt of that and we can understand. If you're not sure whether we should see a patient, there are very few paediatric emergency departments that are not capable of taking a phone call from a GP who's concerned about a patient to understand what your concerns have been and what you've seen. And sometimes we can provide advice over the phone around, you know, ways to manage those things. And other times we'll ask you, obviously, yep, by all means, send that patient in. Very happy to have a look. Appreciating that many times, particularly patients in this cohort, may well spend a long period in our waiting room, which is not to say that they're not under our care. When they're in our waiting room, they are under our care. We have waiting room nurses who will move around that space and are maintaining that kind of continual observation recording observations and just watching what happens to those children over time. And they're obviously, trained to try and pick out the children that they feel things are not going well, and we can change their course through the ED. But those systems are not perfect, but patients, may well spend time in our waiting room, and they are being observed, and that is kind of part of their care in the ED as well. So, yeah.
Taking one step back, Claire, if the treating clinician decides that, no, probably not ED at this point, I'll go the route of giving the red flags to the parents. Yep. Is there a list of red flags? Is there a handy checklist on some website somewhere that...
No,
this is so frustrating.
I totally get it. I think honestly, I think it comes down to, so the red flags that I give to families, if you're concerned that your child is getting worse rather than better, if they're not following, so I'll explain to families, I think your child has a viral illness, I would expect it to go like this. And I'll explain, they might have a little bit more vomiting, or they might have some ongoing diarrhea, depending on obviously what I think the problem is. They might keep coughing for another several days. So I give families an idea of what I think is going to happen based on what I can see of the illness in front of me. But then I would equally say, if you feel your child is getting worse rather than better, I want you to come back. If they become lethargic or drowsy and you feel that they're not responding normally, I want you to come back. If they're not eating and drinking more than 50% of their normal amount, I want you to come back. If they're not passing urine, all those kind of things. And you need to tailor that list to the problem in front of you. But it's basically a list of things for families to look out for in a deteriorating child. It's not a comprehensive list. It's not a list of every single thing that could possibly go wrong, but it's kind of giving them an expectation of what we think their child should do. And if they're not seeing that happen, they're the times that they need to seek help again. And some families, depending on their health literacy, need a bit more description of what that might look like compared with other families who might, have had the experience before and be a bit more health literate in that space.
Yeah. Okay. I've got a comment here that would be interesting to see what you think about. Sepsis pathway will consider antibiotics with 2 abnormal vital signs. What do you think about that, Claire?
Well, I think we've just seen from the evidence that we've shown you from those articles that doesn't help us to predict sepsis. It really comes down to, if you have a patient who's tachycardic and tachypneic, they almost certainly still have a viral illness. And that's why I was mentioning at the very start about overdiagnosis has implications. If we give parenteral antibiotics to children, that has implications for gut biome, for lots of different things going forward, as well as for antibiotic stewardship across the community. And that's obviously, parenteral antibiotics are not a fun experience. It involves injections, it involves insertion of IV lines, all those things, which does create trauma for children as well, and unnecessary hospital admissions, potential to collect other viruses while they're here because we don't have a shortage of those in hospital. And there is consequences to each of those things to do. So there's clearly consequences of if we have a child with sepsis that we then don't move to treat, as well as over-treating children who don't need treatment for sepsis. So to say that simply having elevated heart rate and respiratory rate would constitute need for treatment for sepsis is inaccurate and not borne out by the evidence.
Okay, look, I'm very frustrated. I don't know how you deal with this level of ambiguity and uncertainty, but thank you for that. That is all the questions at this point on sepsis.
Okay.
Let's hope we get a little bit more satisfaction.
Hopefully we'll get a little bit more clarity now.
Yeah.
Okay, so I just wanted to talk a little bit about the other big sort of beast that people always think about, and that is Neisseria meningitis or meningococcus, which is those little raspberries that you can see there, Della. That is in fact a meningococcal bacteria sitting over there. So they cause, essentially, again, same bacteria but causing a number of different conditions. Meningococcemia or sepsis is the one that we're most commonly thinking about. Obviously also causes meningitis, but more rarely can cause septic arthritis, pneumonia, and actually an occult bacteremia where the patient's not particularly unwell. About 10% of adults carry meningococcus in their nasopharynx, just hangs around up there causing no dramas whatsoever. It's a human-only pathogen and just spread through the normal sort of saliva and respiratory secretions. Apparently can also cause urethritis in men, which is quite removed from the other sort of bits and pieces that we've got listed there. So it's really important, and that's why this slide is red, and I apologise, it's not the most attractive colour to look at, but it's really important to understand the difference. This is one bacteria that causes different diseases, and you'll understand why I'm harping on this in a little bit. So exactly the same as group A strep. Meningococcus is a bacteria that can cause several different diseases, but one of those diseases does not result in the other. So meningococcal meningitis is a separate disease to meningococcemia or meningococcal sepsis. Meningococcal meningitis is traditionally much slower moving, and actually the development of meningitis can be protective against the evolution of meningococcemia because you've isolated that bacteria to one location and it hasn't become bloodborne sepsis through direct invasion from the nasopharynx. And more importantly, the absence of meningitis symptoms doesn't exclude sepsis. So we will quite commonly get referrals for patients, queries sepsis, no neck pain, no photophobia, etc. But they're not signs of sepsis, they're signs of meningitis. And it's really important to keep those things separate as clinical entities that we're looking for. So meningococcemia, you'll see this is basically exactly the same list that we were looking for when we were talking about the invasive group A strep. Fever, loss of appetite, nausea, vomiting, sore throat, coryza, headache, lethargy, etc., leg pain, myalgia, and there's that same list of sepsis recognition, serious things that we saw earlier. But all of these things can happen across both of these bacteria. And it's important to remember that a blanching rash does not exclude meningococcemia. You don't have to have a non-blanching or petechial rash to have this condition. So it's important to remember that when you're thinking about sepsis, you aren't hunting a particular bacteria because they actually all present very similarly. So you can't necessarily refer a patient with query meningococcal to the emergency department because that's not a disease, that's a bacteria. So you're hunting the organ dysfunction that comes with the infection. And this is how you can best look for sepsis. So you need to think about and look for the organ dysfunction and think about the sick child. Don't worry about trying to isolate which particular bacteria is causing the problem. You just want to know, is this child very sick? And if the child is very sick, that's when we start thinking about sepsis, and that's what we're trying to find. Which bacteria they're suffering from kind of doesn't matter because at the start, we treat them all the same anyway. So just to sort of think quickly about those principles of sepsis treatment, early recognition, we've talked about why that's difficult and why we always ask our juniors to seek senior help if they're unsure. We assess airway and breathing and we give oxygen. We have rapid vascular access. We provide empiric antibiotic therapy. Doesn't matter which bacteria we think might be causing the problem, it's all the same. We use carefully titrated fluid resuscitation, early initiation of inotropes, and involvement of critical care. We manage source control if there is a particular source for the sepsis, and we provide frequent reassessment to ensure that the therapies we're putting in place are actually having an effect. So these are essentially the standard guidelines for the treatment of sepsis. So as I said, this part is relatively straightforward. It's that the recognition that is the hard part. So when we have a patient that has been identified as having sepsis, which may not be in the first 5 minutes of them being in the emergency department, but it's the first 5 minutes after we identified that we're concerned about this as an option. We request senior assistance, attach monitoring, address any airway or breathing compromise, and give the oxygen. There is no blood test that allows us to screen for sepsis, so I can't simply do a blood test and answer the question as to whether a patient has sepsis or not. There are blood tests that we use as additional pieces of information or dot points on our sort of plot to try and add weight to the information that the patient may have sepsis, but none of them are definitive or answer the question clearly. Then we have, within the first 15 minutes, we need to establish vascular access, most likely insertion of an IV cannula. We take those blood tests and then we administer the antibiotics if we can at that time. And we should never be doing investigations that delay antibiotic administration in a child identified as having sepsis. Then in that first 30 minutes, we're giving our IV fluids, and obviously all of that's detailed there, and we don't need to go into that in any great detail. And if children are requiring significant amount of fluids to maintain their perfusion, then we need to manage them in a critical care environment. And down the bottom is that small portion of children who do require some vasopressor support as well. So this is the antimicrobial guidelines. So this is the whole lot of antimicrobial guidelines in the sort of patients that we're talking about, which are those sort of children, so not the tiny neonates, but bigger than that. We're using a fairly standard ceftriaxone type intervention, and often also with flucloxacillin to specifically cover our staff. So that's the standard intervention that all of our patients would get. It doesn't matter which bacteria we think is causing the problem, they all get the same antibiotics in that first interaction, and then that can be rationalised later if we get culture results or information that makes that more obvious down the track. So meningitis. So meningitis is inflammation of the meninges surrounding the brain and spinal cord. And then we've got this other brain problem, which is encephalitis, or inflammation of the actual brain parenchyma. The two are very, again, difficult to distinguish, so history and exam are important, and there are features that are more prominent in one versus the other. But if you're in doubt about which disease the very sick child in front of you has, then you need to treat for both of those diseases. So thankfully, as I said, bacterial meningitis is now thankfully very rare due to vaccine uptake. And it's difficult to distinguish viral from bacterial meningitis clinically. On spec now, we can mostly say that by far the vast majority of the meningitis that we see is in the context of a viral illness, rather than serious bacterial meningitis as it used to be, certainly when I started practice. But very sick children that we're concerned may have bacterial meningitis are treated with empiric antibiotics until we can confirm the cause. A well child with mild headache or neck stiffness and maybe a little bit of photophobia is very unlikely to have bacterial meningitis. And the vast majority of children in that setting won't even get a lumbar puncture. They'll just have a period of observation, some analgesia, and if things settle down, they don't need further investigation because it's very unlikely to be bacterial meningitis. It's important to recognise that there are a few mimics for meningitis that we probably now see much more commonly than the meningitis that we were most worried about. One of those is invasive sinusitis in adolescents. If you've got adolescents who clearly have an underlying sinusitis and they become confused or encephalopathic, they're actually more likely to have invasive sinusitis than they are to have meningitis or encephalitis. So the risk factors for bacterial meningitis, obviously if you're unimmunised, that places the patient at much significant risk. If they are immunocompromised or they've had history of interference within the brain space, so neurosurgery, they've had a penetrating head injury, they have an existing VP shunt or cochlear implant. And obviously our much younger children are at risk as well, although even then we're seeing it very, very rarely. So when we're taking a history and exam and we want to exclude meningitis as the cause of our fever, we've got that sick child list there again. And probably the most concerning things on there are the photophobia and the altered conscious state. In terms of looking on the exam, looking for hyper or hypotonia, so floppy or stiff patients, specific neck stiffness, or focal neurology. We have lots of eponymous signs that we can look for in medicine, and isn't that wonderful that people have named signs after themselves? But they're actually not clinically particularly helpful in the paediatric population because they're difficult to elicit, and whether they actually correlate with the patient having meningitis is pretty borderline. So they're not things that you need to worry particularly about. You certainly don't need to be looking them up. You need to be paying much more attention to the overall history and examination that you're getting from the patient rather than, eponymous signs. So the hospital treatment for meningitis is lumbar puncture. If we're concerned the patient has bacterial meningitis, then they will get a lumbar puncture. That's not straightforward in a lot of children who may need sedation or even an anaesthetic in order for that to happen. If it's unsafe to perform the lumbar puncture, for example, the patient has focal neurology, seizures, or an altered conscious state, then we will start the antibiotics and undertake the lumbar puncture further down the track. It's really important that we don't delay the treatment of meningitis in order to access the LP. We can look for the exact cause afterwards. It doesn't have to be done before the antibiotics are administered. So thinking about the neuroimaging, so who needs imaging in something like meningitis? So those patients with the focal neurology, with signs of raised intracranial pressure, or who are already encephalopathic, or if we're not quite sure that we're onto the right diagnosis and we're looking for something else happening in the brain, they're the times that we would be exploring the options for neuroimaging. Again, many of our patients will require a degree of sedation for that to happen, and particularly around if we move down the pathway of MRI, which is very uncommon, but they would often require a general anaesthetic. So when we're thinking about the antibiotics that we might use in meningitis, again, you can see there we've got our third generation cephalosporins, primarily using ceftriaxone in this cohort, and we've got other options there if the patient is hypersensitive or allergic to those antibiotics. Encephalitis is kind of the last one that we were going to talk about, and it's really important to understand that we're really looking in this cohort for that HSV encephalitis, because it does have a significant morbidity and mortality, and acyclovir can certainly turn that around. I think the most important thing to look for, think about with encephalitis is fever and encephalopathy. So patients who have an altered mental state, so very unusual behaviour, confused, often altered conscious state, and that they may sort of be very, very drowsy, difficult to wake, etc. They commonly have seizures and many of those other features that you can see there. In terms of examination, well, you've already kind of got the examination as you're looking at the patient. And it is important to have a look and see if you can see any obvious HSV lesions, but there will be a significant portion of patients who have HSV encephalitis who have no external signs of HSV infection at all. And again, because it's very difficult to differentiate our meningitis from encephalitis patients, we're actually treating both of those groups of patients with the antibiotics. And if there's any concerns about encephalitis, particularly where we've got altered conscious state, we will always be adding our acyclovir at that time. And then once we have more information from, cultures and PCR testing, we can obviously, rationalise that treatment as needed. And then the last thing I was asked to sort of mention is the special considerations that we have in our Aboriginal and Torres Strait Islander patients. And as I mentioned, we need to think about treating group A strep sore throat and doing the throat swabs in those patients and treating with antibiotics, and also checking for eradication once the antibiotic course is complete to ensure that there's not ongoing throat carriage in that patient population, and a low threshold for the systemic antibiotic treatment of skin infections for the same reasons, to try and reduce the risk of invasive group A strep. But the sepsis management is essentially the same for all of our patient populations, as I mentioned earlier. So things to remember: sepsis recognition is really hard, but most febrile children do not have serious illness. Group A strep sore throat doesn't require specific treatment unless you have a specific risk. Petechial rash is not associated with meningitis. There's a lot of situations where we've got the same bug causing a different disease. Meningitis is rare and mostly viral, except in our at-risk patient populations. In true bacterial meningitis, we aim for our lumbar punctures within 30 minutes. Otherwise, we give our antibiotics first. And the key to recognising encephalitis is really altered conscious state, and we treat our obtunded children with antibiotics and acyclovir.
Thanks, Claire. We do have a couple of questions. Firstly,
No worries.
Is JE common anywhere in Victoria?
No, not really.
What is JE?
Japanese encephalitis, I assume is what they're talking about. Yeah. No.
Good.
The encephalitis that we see tend to be either sort of non-infective encephalitis, so things like autoimmune encephalitis. We would still treat those patients as though they had infective encephalitis, because it's an encephalitis we can do something about, giving the acyclovir. Some of the others are, much more insidious and difficult to treat, but we obviously treat the things that we can treat, if that makes sense. And then that can be rationalised down the track if other information comes to light that might change the patient's outcome.
Now, when I was doing a little bit of research into this topic to prepare for it, I came across Safer Care Victoria has a checklist for adult sepsis. Can adult checklists, do they apply? Okay, fine. Sorry.
They're trying. I must say Safer Care are definitely on board with trying to develop a checklist for paediatric sepsis, but it is very difficult. And as I said, there's not a lot of information. We just don't have the evidence. So mostly the checklists involve checklists of sick patient lists, which, we've seen several of those there, and they're articulated in different ways. But it's really about picking up the patients that you feel are more unwell or deteriorating than you expect them to be with a viral illness. And I think that's probably, one of the joys of GP and also paediatric emergency medicine is we actually see a lot of febrile children. And the further we are into our careers, the more febrile children that we've seen. And I think the more confident we can be in our abilities to pick up the children that we go, oh, actually, you look much sicker than I expected you to look like, or you really don't look well. Or particularly, I think the advantage for some of our GP colleagues is that, they may know a family very well and have met a child many times before, and now they're seeing a child going, wow, this child looks really much more unwell than when I normally see them, and they can really see that difference, which then, allows them to say, right, I'm really concerned about this child and I do want them to be seen in hospital. And, that's fine. We're happy to review those patients, when somebody who knows the patient well is saying, actually, this patient's really not okay. They're not themselves and I'm quite concerned about them.
And that's the difference with urgent care clinics.
Yes.
And
yeah, they're more like us.
They're in that quite a sort of specific, unique position.
Yeah.
This next question, I think, is just highlighting how frustrating this is. Any references to read?
No, I mean, I've put up a couple sort of in the presentation. I think, obviously we're using the RCH CPG guidelines, which are now sort of reinforced by the tri-states across, Victoria, New South Wales and Queensland. So certainly you can have a look at what's there. Very sort of, clear, again, the sick child lists, and obviously the management of sepsis is very clearly articulated in those guidelines, and the detection is not as clearly articulated because it is difficult, and it's not as clear in there. I think that it really comes down to, thinking about history and examination and really looking for the signs that a child is more unwell than you expect with whatever you think the underlying diagnostic process is, and then making sure that you're really safety netting and red flagging those carers to know when to seek additional assistance if the child's not improving.
And are you able to share these slides, Claire?
Yes.
Yeah, cool. Okay. Next question. Any cutoff level of CRP or OCT help to differentiate between viral and bacterial infection?
No, we literally refer to CRPs as the random number generators. And I'll often have sort of junior staff who'll say, oh, I'm going to do a CRP on the patient. I'm like, okay, great. And when you get that CRP, what number are you looking for? And what number is going to change your thought process? So if your CRP is 0, does that help you make a decision? If the PR, and I'll say to them, what are you going to do if the CRP is 62? And they'll go, what are you going to do if it's 162? Oh, then I might do something differently. Oh, what are you going to do differently? There's no evidence that the CRP helps us to determine which children have sepsis. The CRP might be useful in some infections where we measure it over time. So we measure it today, we measure it tomorrow, we measure it in 2 days' time. And specifically, our orthopaedic colleagues often use it for things like osteomyelitis and septic arthritis to gauge response to therapy. But in terms of diagnosis, it's not useful. So as an anecdote, and I think we all love a good anecdote, early in my career, I looked after a patient who died of meningococcal sepsis, and their recorded CRP approximately 1 hour before they died was 7. So I think that just highlights that using the CRP, super not helpful.
Okay, we're going to play a game, Claire. I'm going to say a phrase, and you've got to try and figure out what it means.
Okay.
This is the phrase prolactin LVL.
Prolactin levels, yes. So
20 cents for you, Claire. That is the.
Oh, did I?
Yeah.
Oh, I'm getting some good money here. So prolactin, we don't have a lot of evidence to help us measure prolactins, and certainly if I request a prolactin from my emergency department, I will get a result probably about this time tomorrow. So if I'm trying to diagnose my patient with sepsis now, not particularly useful. Procalcitonin is the other marker that we can use in sepsis, and in some centres that is readily available. We can measure that here, but again, it's going to be a significant delay. So at this stage, it's quite an expensive test, and it's not yet well verified in terms of there's no clear indication as to yes, it's sepsis or no, it's not. It's one of those things that, again, can go into the mix alongside things like FBEs and lactates and things like that to help us guide or sort of to provide a weight of evidence one way or another. But for us, it's still a test that takes quite a long time to come back. So it's not particularly clinically useful yet, but that may change in time.
Okay, this next question is a little bit about the timing of the progression of the illness. So I think what you said was meningitis and meningococcal perhaps are a bit slower than sepsis. But so let's go with this question relating to sepsis.
Mm-hmm.
Is it better for the infant or child to go with the parents straight to ED or via ambulance if they're really sick? So how fast does this thing go? Should we say go to ED, your parents can take you, or go to ED, I'll get you an ambulance if they're really sick in presentation?
Well, I think it's the main question there is really, do you think the patient needs treatment now? Because if that's the question, then that's when you need an ambulance. And so the reason for calling an ambulance is obviously, urgent transport to hospital, but the difference in an ambulance transporting the patient versus the parents, you've got to weigh up how long the ambulance is going to take to get to you and then the transport to hospital, whereas the parents obviously driving straight there. In terms of how we manage the patients, we don't differentiate our patients coming through the front door versus our patients arriving on an ambulance trolley. They're all triaged in the order in which they arrive, and triaged each on their own merits. So just because you arrive by ambulance doesn't get you greater access into the department. But it's really about if you feel that the patient needs urgent treatment in terms of, they need a cannula and they need fluids and they need resuscitation now, then you absolutely need to call an ambulance, because the ambulance service can provide that to the patient before they reach hospital. So you're getting that intervention and that resuscitation starting before they've even come to the door of the ED. If they don't need resuscitation, then they're very likely to be able to manage coming to the hospital and being assessed when they get here. So if you've got a very sick patient that needs urgent resuscitation, then that's when you need an ambulance.
Hey, Claire, round 2 of Guess This Phrase, you have a chance
Fantastic.
now to double your prize from 20 cents to 40 cents.
Amazing.
Procalcitonin level.
Yeah, that's the one I was mentioning before. So
Okay.
the procalcitonin, we definitely can, we can measure that. But again, it will come back the same day, but probably 6 hours later. And I would hope that we'd made a decision about the patient's status and treated them before that if we were concerned about sepsis.
Brilliant. And you are now the proud winner of 40 cents. Yes. Thank you so much. Look, we don't have any more questions, but I do have a couple of other things that I want to just go through. Do you mind just stop sharing your screen, and I will now share my screen?
Yep.
Brilliant. And I want this particular screen here. Just make sure that you can see the session conclusion slide. Yep. Great. Now, I noticed that in Victoria, there's a couple of, in Victoria, Safer Care Victoria are on to sepsis, and they have got some resources. But also the federal government, the Australian Commission on Safety and Quality and Health, is calling on health professionals to participate in a quick 10-minute, I don't know if that's an oxymoron, but anyway, survey hosted by Medcast to share your thoughts on how we can improve sepsis education and training for primary healthcare professionals. So there is a link there on sepsis and primary practice survey. You can just Google that to get to that. That would be very helpful for people to participate in that, because as we have gathered from tonight, sepsis is extraordinarily ambiguous and difficult to determine. For those in Victoria, I just want to highlight there's cultural awareness training in person this Saturday in Docklands, and it's fully catered and by a very experienced presenter. And lastly, can you please put your phone and do the QR code, because the more feedback I get, the more relevant I can be. And the more relevant I am, the more useful I am to you. So please scan the QR code and give us your thoughts on how useful tonight was for you. Thank you, Dr. Claire, so much for your brilliance on what is a terrifying and difficult to diagnose condition in sepsis, and slightly less terrifying perhaps the others. We don't have any more questions. Just let me check that. No, we're good to go. Thank you very much. I will then finish this up a bit earlier so everyone can go and get a cup of tea. And if you haven't had dinner yet, please go and do that.
That's me. I'm having dinner.
Good, good. Go and have dinner. And yeah, thank you so much, Dr. Claire. As usual, it's been an absolute pleasure. Thank you very much, everyone.
Thanks, Stella.